The following Agio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak to a healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
What's up, Cheat Codes listeners? It's me, Dr. Z.
And me, Dr. C.
Dr. C, we, when we set out on this journey of cheat codes, the intention was to, capture sickle cell at a really interesting turning point in history.
We picked good timing. I think this is the golden age.
Yeah, it feels like we're kind of building a time capsule where people will look back and wonder what happened between sort of 2020 and 2030. When did this shift in sickle cell care occur? Who were the key players when that shift was happening?
I feel like we found an earthquake this week. There was a big shift, at least in my thinking.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, partners, and each other. Building on these connections and the company's unmatched leadership in PK activation, Agios is pioneering therapies for rare blood disorders, including PK deficiency, thalassemia, and sickle cell disease. To learn more, visit us at agios.com. That's AGIOS.com. To join the conversation with other patient allies, follow us on Instagram at Ally Voices Rising. That's Ally, A-L-L-Y, Voices Rising.
Spoiler alert, we are recording from Stowe, Vermont. What brings people who care about sickle cell disease to Stowe, Vermont?
Other than the Ben & Jerry's?
I just found out about the Ben & Jerry's today, man. I'm excited. We're going to have to go there.
No, we're here for the National Alliance of Sickle Cell Centers meeting.
And I've got to tell you, it's when we left practice, this was an idea that I was starting to hear about, but never had the opportunity to participate in while I was still caring for patients with sickle cell disease.
Yeah, I think when we left practice, this was a seed.
Yeah.
And this week we saw the fruit. It's amazing.
It feels like it's not only just fruit, it's a tree that's giving shade and protection and pulling people together, and I think there's a lot to celebrate. So to that point, our guests today are here to tell us the story of the National Alliance of Sickle Cell Centers. We've got Dr. Julie Kanter, Dr. Sophie Lanzkron, and Dr. Marsha Treadwell. Welcome to Cheat Codes.
Welcome.
Thank you. Thanks for having us.
Of course. Dr. C and I, we walked into this meeting for the first time. This is our first time attending. And I've got to tell you, it's been impressive from the first time we walked through that door. You guys have really done an outstanding job. But we have so many questions around, number one, how does something like this come to fruition from people who have full-time jobs taking care of, patients that need a lot of care? How did this all come about in the first place?
Oh, there are so many components of the National Alliance, so many roles that it needs to take. Right. A lot of this is about community and building community and finding people who have the same ideals and same principles about taking care of a population that needs care. And so a lot of it grows out of the community that already existed and the recognition that we needed to build our numbers. And so part of this came from the American Society of Hematology Sickle Cell Disease Workshop, where we were building up centers and creating centers and realizing that there really wasn't a next step. And so mostly Julie thought and really took a plunge that I'm not sure the rest of us would have done without her leadership in making this happen.
It was 2020 by then. We really conceived of this in sort of 2019-ish. We both remember being in a meeting. I don't actually remember what the meeting itself was for.
It was a workshop.
Was it the first workshop in 2019?
Mm-hmm.
And saying this is great, but this isn't enough. Really realizing that people needed community. I can't remember when you guys left practice, but
2020.
Yeah, about a fifth of our workforce actually left in the span of time between about 2017 and 2021. And as I watched all of these people leaving, I thought, God, we've got to do something to make people stay and keep people happy. And this is hard work and give people a place to come together and learn from each other because, right, we still every other sentence that we say about sickle cell is we don't have any data. And we didn't really have a group helping get us data and helping us do the work that we wanted to do, which was to truly improve clinical care, not just new research and new therapies, but how do we just provide the best care possible? And, in 2020, we were bored, right? Nothing was happening in the world. So it was a great time to adopt a second career and form the National Alliance. And, Marsha Treadwell was with us, and Deepa Manwani was with us, and actually so was Kim Smith-Whitley in the original founding.
Yeah. What do you remember about that, Dr. Treadwell?
I was going to comment that besides the ASH sickle cell disease workshops, I think another foundation has been the Sickle Cell Disease Treatment Demonstration Program. And so the Sickle Cell Disease Treatment Demonstration Program was funded by HRSA some years ago. In 2014, it was shifted to a regional model. And so there were 5 regions for the purpose: Northeast, Southeast, Heartland, Midwest, and Pacific. And that structure of these regional models, we're also all regional leads who are a part of this NASCC group. And so I think that also landed communication, structure, that we were focused on improving access to quality care. But as Julie and Sophie has said, what we were getting to help us do that wasn't quite enough. So a whole new thing had to be birthed.
Wow. It's impressive.
It is. I mean, I've been hearing a little bit about this, mostly from new young people in sickle cell. And they'd say, I went to this meeting and we were working on consensus guidelines. And I showed up this week and there were 320 people here and another 150 online. I didn't even know there were that many people working in sickle cell. It's been great to see. Having heard a little bit about how the idea started, I'd like to hear more. What is NASCC? What is the organization going to do? What does it do?
Well, it expands every day these days, I think. The organization was really put together to be a place not just for the doctors, not just for nurses, but for every member of our sickle cell center teams. And I think that's what all of us know, right? We all know that this is a team event. None of us do this as single individuals. And it was one of the problems with some of the other communities that were out there, is they were so geared to the doctors, and we wanted something that encompassed the whole team. And so we've expanded as we've gone, and we hope created a place that's not just for physicians, but a place for our APPs and social workers and nurses. And now they're all putting together some of their own consensus guidelines and putting together white papers on who they want to be and what advancement looks like. So I think we have a lot of different places we hope to go. I think one of them is certainly to grow this meeting just a little bit more, maybe not too much, but also to continue to be able to really initiate true quality improvement, comparative effectiveness research. Harness what was started as Granddad that we adopted as the National Registry, the Global Research Network for Data and Discovery, Granddad. And to harness that, get everybody excited about the work we can do, because it's what we need to make care finally better in this disease.
I think one of the things that we had sort of before NASCC, but part of the SCDT program that Marsha talked about, was these echoes, these telementoring, where people would call in and sort of listen to experts and sort of standardize the way we deliver care, right? Like that had never existed before. We still have, we had the Sickle Cell Adult Provider Network to provide support, but the idea that we all see complicated patients for which you cannot just look up and up to date about what you're going to do about it, but to have sort of a community that said, well, this is how I would manage it. And from there, right, the idea that we don't have a lot of data for what we do, but that we need to pick some level of how we're going to practice and how we're going to approach these problems. And we could wait another decade to ever to get evidence base, or this process that Julie and the group has been using, these modified Delphi, to come up with consensus recommendations for how we practice, which is a really powerful tool to sort of make sure that there's some level for how we're practicing, and then we can use Granddad to sort of look at quality and quality improvement.
That's fantastic, and you're exactly right. I mean, the dynamic nature of sickle cell disease makes it very hard to find good resources that help us care for these individuals. I'm a little curious about the centers themselves. Walk us through, to the people who are listening. Who are these centers? What is a NASCC center? What does that mean?
So all NASCC recognized centers have to deliver coordinated, comprehensive, compassionate care. And what does that mean? It means that it can't just be a physician. It has to be led by a sickle cell specialist who is a physician, but they also have to have a multidisciplinary team. So you have to have social work, you have to have nursing, you have to have a plan to be able to not just do sickle cell disease therapy, but pain management to make sure that you're providing for fertility, whatever that means for those individuals, for ensuring ongoing assessment of both emotional as well as physical and social well-being. And so not all the centers do it the exact same way. There's some components that each center has to have. They're what we call standard components, and then there's some that are similar to our recommendations, recommended. Some we'd all love to have, and some that are somewhat more aspiring, I think, in some ways.
Okay, I love that. So there's a nice little map. I mean, in fact, yesterday when I walked into the meeting, it was great to see so many familiar faces. But I think one of the really cool parts for me was seeing a lot of new faces. Is that something that you guys were anticipating? That there was like the traction that has come into this? Has it surprised you as well?
Hey, people want to be in with the in crowd. And we purposely are making efforts to help young people to be successful, especially in academics, where most of these centers are, and provide opportunities and mentorship. And we want it to be a warm and welcoming environment for everyone to feel like they belong. This is not a clique. It can be a sickle cell clique, but it's not like the leadership clique. It is really to engage and bring people in.
Yeah, and I mean, we certainly saw that yesterday. I feel like the demographic is definitely very junior leaning in many instances, which is beautiful to see that spotlight being on sort of some of these newer faces in sickle cell disease. So hats off to y'all for doing that.
Some of the work that Dr. Treadwell has really been instrumental with is involving our psychologists and our neurocognitive specialists and in the neurocognitive work group. I don't know if you want to talk about the work you all have done, which is pretty amazing.
Sure. So I'm a psychologist by training, a lifespan psychologist, and the psychological well-being of people with sickle cell disease is central. Pain affects psychological being and vice versa. And so, the complications that we see often have an overlay related to the mental health that the person is experiencing. So the opportunity for psychologists to come together is also really very exciting. And one of the groups that started under the leadership of Alyssa Schlenz in Colorado is a neurocognitive work group. So experts in cognitive status, psychology came together. There are physicians on that group because you don't have to be a psychologist to be an expert on brain. But the group has come together and again now has developed consensus guidelines based on working together to come up with standards and recommendations and then send those out for a vote. And now the psychologists are coming together. So there's a mental health track, and that's still evolving. Psychiatry's with that group. Social work is separate, but again, we're still evolving, and that's really the nice thing about NASCC is it's very organic. We come together and things start to we start to figure things out. And what you noted about people being junior and how exciting it is to see that is I'm attending virtually this year, but it's still been really a great opportunity where we all learn from one another. So we look at how people are doing things in their own centers, and although there's that core of essential elements. Like last year, I really learned about the pharmacy role from University of Alabama, or I learned about, and others learned about the psychologist role that I've been doing for a long time. So that's another part of the learning is that we can see just new possibilities in the care of these teams as these teams are created to care for people with sickle cell disease.
One other piece I just want to add that Marsha's played an integral role is also sort of bringing in the community, right? The community-based organizations. We have, I think, pretty good representation this year at this meeting of members of the community, and Regina is here, and others are here from the community itself. And as we go through some consensus recommendations, it's really important to have the community in the room, right? We don't want to make these decisions without the people who are living with sickle cell disease participating.
So the CBO partners who do attend get to be part of those consensus discussions?
They are part of the discussions. They are not NASCC centers, so they don't get to vote, but they're part of the discussion, and I think their input's really important.
That's amazing. It's so important to have the patient voice represented there. So that's, kudos to you all for that.
Yeah, and we really rely on them for their own standards and best practices. But what's great is that we're coming together in partnerships. And, our focus is on the clinical care. And so that's a particular activity of many of the CBOs. They may have different things that they're doing. So as Sophie pointed out, NASCC is about the clinical centers, but we have to do it in partnership. And so the door has been opened here at NASCC to really partner with the community-based organizations, community health workers, and so on.
And I think, too, to integrate everybody together so that everybody struggles with their own issues, right? Nothing's perfect. So it may be hard for us to get a patient into clinic, and at the same time, it may be hard for the community to figure out how to help that patient. And so how do we come together to help those that need it? And how do we start working towards those same goals so that we're not working in opposition, but we're working collaboratively? One of the other reasons I think the Alliance is so important is we really have tried to ally with everybody, meaning we don't want to get in anybody else's lane. We're not in this to become a clinical trials network. We really are. We want to be the voice of we want to be the voice of clinical care for individuals living with sickle cell disease. And we also needed a place where we could all collaborate and ask everybody to come join us. And that's been really important because the history of sickle cell disease, unfortunately, is often competitive and the opposite of collaborative, whatever that is. And that's just because there hasn't been enough money, so nobody wanted to share. And so one of the goals of the Alliance is to pool the limited resources we have. So we use Granddad as our registry, so does the HRSA Sickle Cell Disease Treatment and Demonstration Project. We had one of my grant meetings, one of my RO1s, we met up here because then essentially the people who are attending the grant meeting can stay and attend the conference. So it becomes sort of a 2-for-1.
Yeah, that's lovely. To be able to optimize in that way is so beautiful and so important for people who have limited bandwidth, but still need to be present in all of these things. Go ahead, Mike.
And I can see, and I wonder if you've heard feedback on this, that as you build up a consensus about, what is required to take care of sickle cell, specific clinical problems, how they should be managed, are people able to go back to their medical center and leverage that and say, we want to be a sickle cell center, we need access to psychology, we need a social worker.
Actually, yes.
We need erythrocytophoresis.
Yeah. In fact, the first paper we did about what a sickle cell center was, I can't tell you how many centers said, I took this to my C-suite because they didn't believe I needed a social worker.
Wow.
And it's really true, sadly, in the state, I think, in a lot of that we're in, if you don't have it written down and there's no rules, nobody has to do it.
Right.
And I'd heard that from my colleagues in the cystic fibrosis world, and they get scored. Their centers get scored, and they can get put on probation.
Interesting.
And so when they're on probation, that they're on the Titanic is what it looks like. And so in some ways, we also had to create a world, I don't want to say that was more legitimate, but was more recognized so that our hospitals would recognize us.
It's amazing that this can be, leveraged for that type of support. It's definitely necessary, particularly for some of these junior faculty that probably don't have voices helping them out internally.
Can I comment?
Of course.
Sorry.
No, please, Dr.
To follow up on that, there's also the possibility for a center to be an associate center. So if people don't have those required or essential elements, then it's important for them to partner with a sickle cell center that does have those elements. And so they can come on as an associate and then build up to being a full member.
Yeah, actually, this year, a couple hours ago, a group that I didn't even know existed from Tulsa, Oklahoma. They are a St. Jude's affiliate, but have not been very well resourced in the hematology space. And I was shocked to see 3 of them here.
Wow.
They're an associate center. They don't have quite everything they need, but they came to learn, and they were so excited to see the community. And I think that was really cool.
That's great. That's great. So I love this idea of, it's very organic. You're building things as sort of it makes sense. But what is, if I can ask, what is the long-term vision? Have we thought about this as NASCC? What does NASCC look like in 5 years?
There's so much work to do. But from me and from my perspective, one of the key things we really need to do is the quality improvement piece, right? Following in the footsteps of CF, where they used their registry to really see why are people in Oshkosh doing better than people in New York City, and comparing it and looking at what practices were that made a difference. And just by doing that, they improved overall survival. And so I think there are lots of things we can do just on a basic level by pulling in the quality improvement and pulling in the data from the registry to understand the differences in practice and how that results in different outcomes. So I think that hopefully that will become more robust in the next few years.
Sure. Dr. Kanter.
Other things, lots of aspirations and dreams. We would love some sustainable funding. That would be great. Some form of, in some ways, I don't see it happening right this second, but it would be great to be recognized in some way on the federal level as a sickle cell coordinating center, recognizing or an accreditation center. We've talked a lot about moving right now. What we call is we're doing center recognition, meaning you have to have all the components. And we have each center attest that they have these components. We'd love to move into accreditation, which would involve a lot more funding, but also we'd have to do some form of site visits and checking to make sure that sort of all the things are true. And I do think all of that also brings more validation to sickle cell and to sickle cell centers. And so that's going to take a whole nother level of funding, but I think that's kind of one of the next goals. And it's how we use that registry. And I think it's the most important thing we can do is create this longitudinal registry. We have to understand why certain medicines work and who they work for. We need to know who should get gene therapy when they're young or a bone marrow transplant because they're going to have severe disease and who won't. And we've had no ability to do that, which is just pathetic when you look at the fact that we've known about this disease for so long.
Dr. Treadwell?
Yeah, I'd say in 5 years, the aspiration really would be to have this access to quality comprehensive care, not just by having the strong clinical centers around the country, but having it that people can find the centers, that the community-based organization knows where to refer, and vice versa. And so the other piece of that is this partnership between the community-based organization, whether it's with a community health worker or the organization per se, but just increasing that access by having the centers, but also by having people be able to find them easily when they're looking for a NASCC approved center.
And Marsha reminded me, the other goal that we've had for a long time is developing our affiliates. So not just associate centers who are going to kind of grow up and be full sickle cell centers, but how do we have, I'm in Alabama, I'm in the middle of Alabama, I'm in Birmingham, and I want to have affiliates. So maybe it's a nurse practitioner in a different healthcare setting, or in Mobile right now within their cancer program, we have a nurse practitioner and a social worker who are dedicated to sickle cell disease, so that they can manage individuals who are 4 hours away, who don't need to come to Birmingham all the time, but get the same level of care that they would if they were in Birmingham. So how do we leverage that hub and spoke model, and how do we take it to the next level? I think we want to do as much as we can to treat people where they are. Yeah. And I think that's another big premise, is make sure that everybody living with sickle cell disease has access to a sickle cell specialist and as close as possible to where they are.
Makes a lot of sense. Dr.
Well, yeah, and right, identifying the people for these expensive transformative or curative therapies in transplant, right? Making sure that the people who should be referred for those are able to access them, and that they're the right people at the right place, the right time, getting the right therapies. And I think the hub and spoke model is a way to make sure that people, no matter where they live, are even aware that these therapies exist and have access and an ability to be able to get those therapies.
So to that really important point, I've been hearing about these consensus discussions that are happening around important clinical or meaningful clinical decisions that happen day to day in sickle cell centers. As far as outputs that get generated from the discussions that are had at NASCC, what does that look like? Are these publications? Are these white papers? Are these meant to be shared sort of only with the centers that participate in the discussion, or are they meant to be shared more widely?
So definitely more widely. And in fact, so these started with, I had participated in another Delphi project and learned about this methodology and felt like we could apply it here. But it goes back to the ASH workshop. We're teaching these new centers how to be sickle cell centers. And they ask a very simple question. Well, how often should my adult 25-year-old with hemoglobin SS be seen? You can't look that up. And so we said, okay, we have to come together and answer some of these questions, but also make that information easier to find for everyone. So ASH has done some great work with this, the central nervous system guidelines, the pain guidelines, but it was all sort of disseminated in these different areas as opposed to one cohesive place that you could find. So we started with these screening recommendations, and we now have recommendations for screening of all age groups, screening and maintenance health, and then also have acute pain management recommendations, and we have neurocognitive recommendations, and we have transformative therapy center recommendations. And the recommendations, the tables themselves are actually right there on the website. So anybody can see them, anybody can download them, and we want them to be better disseminated. So one of the things we talk a lot about with our community-based organizations is they should know that too. So they can ask our adults, like, have you gotten your eye exam? Or, have you seen your sickle cell specialist? But we also are publishing them as well. One of our most recent, so we've had 2 publications so far. The explaining this Delphi method, because it's a little bit different than traditional Delphi, so that we could expand it to a hybrid model to involve more people. But also, so that one's been published in the Journal of Sickle Cell Disease. And then just recently, the transition guidelines and the transition recommendations for what goes in a transition note have also been published recently in Blood Advances. So the goal is always publication. And it gives our young members too. We want our juniors to be the first authors on these papers.
And there are some real practice changes, I think, that around the management of pain that everybody is sort of knows, but there are some difficult and challenging changes to our approach of acute pain and understanding the difference between chronic pain and acute pain, and those recommendations for how to manage acute pain, to not use diphenhydramine IV for patients because of safety issues, are now available on the website and will eventually be published. But those really help these centers be able to say, we are changing a policy that has been unsafe to make it safer for people living with sickle cell disease, and to try and move towards improving outcomes. And it's really hard to do that on your own without some written document that says, nope, this is really what the consensus is about how we should be practicing.
I remember going to meetings and talking to colleagues about a difficult case, and it was always, I trained with so-and-so, this is how they did it. Oh, I trained with so-and-so, we did it different. And there was never a venue to hash out what's the right way to do it. So with these consensus statements, are you tying it to some, prospective outcome measure that you can capture in the registry as well?
So some of them, yes. Some things you can't capture easily, like how often someone should be seen in clinic. That's a hard question to answer. But can we already identify, and we've done this in some early work, that people who see sickle cell specialists have more use of disease-modifying therapies? Yes, we've proven that already. And we can see that in the registry. Like the lowest bar that we want is to increase the number of people seen at least once a year in a sickle cell center, because we know that you're going to be more likely to be on a disease-modifying therapy. So we can start to see that. I think the long term, are we improving quality of life? Are we improving mortality? We're going to have to see that 10 years down the road.
And that's one of the things that we do capture in the registry. We have patient-reported outcomes, including the Ask Me Quality of Life tool, as well as fatigue, because these are really important questions just because people are plugged into sickle care or on disease-modifying therapy. The things that are important to patients is that their quality of life is improved. They have less fatigue. So these are part of the questions that we're asking as well.
Give us, for the people who are listening that may not be familiar with what's sort of been discussed over the last several NASCC meetings, give us a high-level overview of some of the consensus discussions that have occurred.
So, as I mentioned, we started with just how often should you be seen as an individual living with sickle cell disease and what should happen at those appointments. From when you're born, the importance of newborn screening, but also newborn screening follow-up, what that looks like, and then how often should you be seen for the first 2 years of life, and then after that, what labs do you need on an annual basis? When should you have red cell blood genotyping? Things like that. Onward into some things we already knew, like the importance of a sickle stroke screen or TCD. We know how often those should be done, and what we learned in an earlier study was the people who weren't getting them were just not being seen. So how do we start designing ways to keep people in, as opposed to just taking care of the people in front of us, but making sure we're taking care of everyone who should be in front of us? And then on the adult side, really thinking about how to operationalize some of the guidelines that were there. So, for example, the CNS guidelines recommend an MRI as an adult. Well, that's very hard to operationalize. So what does that mean? So we had to put that into a framework that was more implementable to say, an MRI within the first year of care as an adult in an adult center if you haven't had one in the previous year. So that was the first year. And then we also had acute pain. It just took us a few years. Yeah. So we worked very hard and brought it to the community to talk about it for the last few years before we put acute pain in stone. Because we know that some of the things like the lack of IV diphenhydramine, which we know is in some ways helpful because it does cause euphoria, and that is comfortable. We can all understand that if you're in acute pain and you want to feel better. But the risks are just too great. But we also knew that we had to be gentle and take that to our community-based partners and talk about why it was so important, that we weren't doing this because we wanted to be punitive. The neurocognitive work, we also started that in year one. It took us a couple years to get that final vote in. And then we had some topics of interest that didn't reach any consensus, and so we actually had to go back and start over. So one of them this year was fever. So it turns out when you're 15 years old and when you're 18 years old, we might treat fever a little differently. And so we could not come to any consensus. And so we said, okay, we need to not even try. We got to just scratch this. And this year we had a whole workshop essentially on infectious disease and fever and what that looked like. So that when you're a child and you move to adult care, you're getting the same message. Because that was the other thing I think we learned, especially in that first meeting in Miami several years ago, which was that the peds and adult groups just really weren't talking to each other. And so we had to get everybody in the same room. And, there's some arguments, but no fights have broken out. The transition stuff that we talked about, what am I missing that we've done? Iron, how we treat iron.
And I think the concept of opioid failure, there are some people whose pain persists despite being on large doses of opioids. And what does that mean? And how do we think about it? And sort of sharing that information and building that into acute pain management.
It's quite a comprehensive, thorough list of topics for sickle cell disease. It's very impressive.
Well, I think the other thing we learned was we cannot do it all every year. Right. So we are sort of, the pace in which we are going through these has slowed a little bit.
Yeah, and I think that is important too, because we just couldn't keep up. We couldn't publish. We couldn't get everything done in time. And we didn't want to be voting on something just in time to change it, because that's the other thing I think that's important is we know that things change and data changes. And so when a new element comes up, we're going to have to revisit it. And the best one actually this year that I've already learned about is since we made these original screening recommendations, so now we actually have to change what we said initially because there's a new vaccine that works better than one of the old ones. And so the infectious disease group actually started that process of a preliminary discussion and a preliminary vote so that we could move it forward through the whole process.
Are these consensus of the whole organization, or do you create like task force, like this is the transfusion group, this is the pain group, this is the
It's a great question. So for now, we do have committees. So for example, Marsha Treadwell and Alicia Schlenz and a few others who've really worked hard in the neurocognitive space, they worked on those on their own. But when it went to final vote, it had to come to the whole committee. And so the whole time we've done that. We've always divided in the beginning. So everyone, all the centers that are active at that time take an initial vote, which is much a how should we do things as a what do you do right now kind of question. And that helps us understand where there's significant differences. And then when we meet at these meetings, because we can't do it all, we have smaller groups meet in person. This year, they're a little bit bigger because we only had a couple of main topics. But then those groups will vote, and then they'll go out to the centers. And we need at least 2/3 of the centers, preferably 3/4, to respond, which takes a lot of badgering, but we get there. And then it's one vote per center.
You know, doing important work like what is happening with NASCC probably requires working with others. Tell me a little bit about how that goes about. Do you have partnerships?
So yeah, we have actually 2 really exciting partnerships, and I hope more coming. So we have our partnership actually has a name. It's called Bet on Blood, and it's Blood is Essential Therapy. And already it's just opened my eyes because I know this sounds a little silly, but I don't think I realized how many blood providers were out there and how the blood providers weren't completely talking to the sickle cell doctors or centers, and our centers weren't always communicating well with the transfusion experts, and there was really no overlap. So there's the AABB, which is the blood bankers, and then there's ASPA, which is the apheresis groups, and then there's the blood centers, and these groups really don't talk enough. And so this Bet on Blood project has already started to be really strong in bringing these groups together to the same table, thinking about how do we make apheresis more accessible for patients and things like that. So that's really exciting. The second one I'm most excited about is our Quilt partnership. That is really geared towards improving access to coordinated care in the chronic disease setting. So sickle cell is their first effort, but it won't be their only effort. And their goal is to create technology that allows us to enhance care coordination in various ways.
Very cool.
And so they have really been great. They sponsored our Quilt Jam last night, so our big 80s party.
Well, that's fantastic. Thank you for sharing that with us, Dr. Kanter. You know, as we're wrapping up this episode, there's a few things that I think are really important for us to address. The first is for those who want to follow what NASCC is working on, what they're up to, what's the best way for them to follow?
There are a couple of different ways. The website actually just recently got an overhaul, and it's beautiful.
Okay.
So sicklecellcenters.org, one great way. This year, we're finally actually going to get a newsletter out. So on the website, you can click to get news, and you'll be able to get that newsletter. I finally got out of the way so that we could get that moving. We also will have a lot of email announcements and blasts, I think, like other groups. But definitely the website and then getting on the email list are going to be the best ways.
Okay, perfect. Social media?
LinkedIn has become the flavor of choice these days. Okay. Facebook's for us oldies. Yeah. So we use a little bit of Facebook, but the kids aren't there. But there is a lot of activity on LinkedIn. So right. I think for now, that's going to be the main area.
Awesome. I mean, with all the work that's happening, I'm certainly going to be following along and keeping an eye on what's happening with NASCC and the centers that are affiliated with NASCC. Once again, all I have to express to all of you today is the utmost admiration for taking on another full-time job and trying to make sickle cell disease just a little bit better every single day. It is a huge undertaking, and we are so much better for your involvement in this space. So thank you tremendously.